Welcome everyone. In this video, we will be discussing a structured approach to diagnosing and managing urinary tract infections. First, let's discuss the clinical features. Common symptoms of UTIs include frequency, urgency, dysuria, incontinence, nocturia, and suprapubic tenderness. In healthy perimenopausal non-pregnant women, these symptoms often indicate uncomplicated cystitis. However, in men with UTI symptoms, always consider prostatitis and perform a digital rectal exam to evaluate the prostate. Some findings on DRE that would support a diagnosis of prostatitis include tender, enlarged, or boggy prostate. We next distinguish complicated from uncomplicated UTI. A complicated UTI is defined by the presence of acute UTI symptoms plus at least one of the following: fever, chills, or rigors, signs of systemic illness, costovertebral angle tenderness, flank pain, or relevant host factors such as male sex, pregnancy, renal transplant, or anatomical or functional urinary tract abnormalities. Complicated cases are more likely to involve resistant organisms, and as a result, they require longer courses of antibiotics. On the left-hand side, we have uncomplicated UTI, also known as cystitis. The diagnosis is primarily clinical, but supported by urinalysis, specifically pyuria, defined as more than 10 white blood cell counts per high-power field, and positive nitrite and leukocyte esterase, which have a combined sensitivity of 68 to 88%. This means that while these urinalysis findings are helpful, they will miss between 12 to 32% of actual UTI cases, so clinical judgment is going to remain really important. In women presenting with dysuria and frequency, but without vaginal discharge or irritation, there is a more than 90% likelihood of a UTI. So in these cases, urine testing is not going to be necessary unless the patient is immunocompromised or has risk factors for complicated UTI. Importantly, the absence of pyuria strongly argues against cystitis. Nitrites, which indicate the presence of Enterobacteriaceae, is going to support the diagnosis, though some organisms like Saprophyticus don't produce nitrites. The differential diagnosis is going to include vaginitis, urethritis, structural abnormalities, pelvic inflammatory disease, and nephrolithiasis. Microbiology in uncomplicated cases usually involves E. coli, Klebsiella, Proteus, and Saprophyticus. Enterococcus is rarely a true pathogen in uncomplicated cystitis. Treatment options are going to be nitrofurantoin 100 milligrams BID for 5 days, or trimethoprim sulfamethoxazole BID for 3 days, or we can do phosphomycin 3 grams once. A mnemonic that you can use to remember these medications is NFT. A lot of people know that nitrofurantoin is a treatment for uncomplicated UTI, so you can use the abbreviation for nitrofurantoin, which is NFT, to remember the other drugs that are used to treat uncomplicated UTIs. So the N is going to be for nitrofurantoin, the F for phosphomycin, and the T for trimethoprim sulfamethoxazole. Additionally, we can utilize beta-lactams like augmentin or cephalosporins for 7 days if resistance patterns or intolerance dictate. We also need to avoid nitrofurantoin if creatinine clearance is less than 40, and we need to also avoid trimethoprim sulfamethoxazole if local E. coli resistance is greater than 20%. Both trimethoprim sulfamethoxazole and nitrofurantoin should be avoided in the first trimester and at term in pregnancy. On the right-hand side, we see the approach to complicated UTI. Around 30% of these patients may be bacteremic, meaning that bacteria are present in their bloodstream in addition to the urinary tract. This finding is particularly common in older adults and those with systemic signs of infection. Pyelonephritis is always a complicated UTI, and it may itself be complicated by a perinephric or a renal abscess. The presence of white blood cell casts on urinalysis suggests upper tract involvement. Microbiologically complicated UTIs may involve organisms beyond the usual pathogens, such as Serratia, Providentia, Pseudomonas, and Citrobacter. If Staph aureus is identified in urine, bacteremia should be considered. These cases often involve drug-resistant organisms, particularly with fluoroquinolones and trimethoprim sulfamethoxazole. Diagnosis should include a urine culture in all cases and imaging if the patient appears systemically ill or there is a concern for obstruction, abscess, or poor response to therapy. Treatment is going to be based on the clinical setting. In the outpatient setting, we're going to be using cefpodoxime 500 milligrams BID, levofloxacin 750 milligrams for 5 to 7 days, or trimethoprim sulfamethoxazole BID for 7 to 10 days. Additionally, single-dose IV ceftriaxone may precede oral therapy. In the inpatient setting, empiric options include IV ceftriaxone, cefepime, or piperacillin tazobactam. Adjust these based on culture and sensitivity, especially in suspected extended spectrum beta-lactamase infections. Oral step-down is going to be appropriate once the patient approves, and the duration is going to depend on the agent. 5 to 7 days for fluoroquinolones, 7 to 10 days for trimethoprim sulfamethoxazole, and 10 to 14 days for beta-lactams. Some special considerations to keep in mind: we need to avoid nitrofurantoin and fosfomycin in upper GU tract infections because they're not going to achieve adequate renal tissue concentrations. And we need to remove or replace any indwelling urinary catheters. For prostatitis, fluoroquinolones are preferred for their prostate penetration, with treatment extending up to 6 weeks. So thank you for watching this video. I hope this video was helpful in your understanding of the diagnosis and management of urinary tract infections.